Good morning. Morning, guys. How you doing? So far, so good. What? Oh, yeah. So this is today's message, most important message in today's class. So, well, first of all, make sure you log in and that's your password. But then I guess the message I want you to get is that antidepressants, well, first of all, they really work, okay? And second, you just have to give them some time, 2 to 3 weeks, remember in the notes? Okay. I'm sorry. Am I sick? No, but I probably didn't have enough sleep, maybe. It's because of you. I'm just kidding. Anyway, so 2 to 3 weeks is actually important. You know why? Because, first of all, it takes people energy to decide that they want to go and see a psychiatric. It's, lots of stress to think that you need to go there. So when they do, they take the medication, they start for a few days, and guess what? They see nothing, right? So they just throw the medication away, return it to the pharmacy and say, it's not working, right? So it's important for you as a pharmacist to know that it takes time for these antidepressants to work, from 2 to 3 weeks, okay? So they should be patient and they should take the medication long enough. And then, guess what? After 2 to 3 weeks, they feel really good, right? And no depression whatsoever. They come back to the pharmacy and say, I don't think I need this medication. Right? It's like, yeah, I'm doing good. I mean, I'm not even sure why I even had to go that route, right? And then you're going to explain them, well, guess what? The medication is working. Yeah, I mean, like, believe it or not, there's some cases where people would stop the medication and then think that too. I'm feeling good. I mean, what are you talking about? Just forget the medication. And then they go back and get depressed again. So you will learn from clinical faculty more about, how to handle these situations and how long someone should stay on an antidepressant. As far as I remember, I think it's at least 6 months to 1 year to make sure they get into the habit of thinking positively and then gradually, wean them off this medication. So just keep that in mind. Now, did you find out why does it take 2 to 3 weeks? Yes, you did. So what is it? Why does it take 2 to 3 weeks? Huh? Receptors are desensitized. So first, when you block the metabolism of these serotonin or norepinephrine, the receptors will have a lot of these neurotransmitters to bind to. So then they get desensitized. So it takes them a while to realize, no, that's the new way of life, right? It's the new way of neurotransmitters being released. So this is a happy person. Let's just continue, with being excited. So the receptors takes them 2 to 3 weeks to get working. Okay. Right, let's see who's not ready yet. If you're not ready, can you raise your hand up high? 1, 2, 3, 4, 5, 6, 7. Okay, let's wait a few more minutes. Any questions about the objectives or about reading material? Yes, sir. You have a question? No questions? Yo? Was not a question, was a comment? No? Okay. Yes, ma'am. Yes. Yeah. That's a good question. So desensitization, are they caused by antagonists or agonists? by agonist, right? Or basically by agonizing the receptor. You know, you could, if you inhibit the metabolism of a neurotransmitter, then you have more of that neurotransmitter, so it's like an agonist effect. Let me check now. Who's not ready? Raise your hand up high so I can see. Hi, 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 hi. Only one person, okay. So do you think you'll need a paper copy or is it gonna work? Do you think, you don't know? Well, I'm glad you are wearing the yellow band today. Have you guys received this yellow band? No? You wanna explain to them what this about?
This is, you're supposed to speak up and reach out.
Okay, about what?
I think it's about abuse and stuff, harming others.
Yeah, suicide or harm yourself, right? Just antidepressants, right? It fits with today's topic. Yeah, so do not commit suicide, okay? Use antidepressants. Okay, so do you think you got it in? Okay, we'll go ahead and start. I'm gonna set the time for 10 minutes, okay? Good luck. Okay, you could start working as a team now. Okay, so let's go through the questions really quick. So do you guys prefer the true false questions or MCQ? Which ones do you prefer? Not true false? Really? I was thinking true false are like easier. No? They're not? Because one of the comments was like, no more true false questions, pretty please. I was like, what? I was thinking true false questions are much easier than when you have to deal with multi, MCQs, but you prefer MCQs right then. Okay. All right, more MCQs. Okay. First one, short-acting non-benzodiazepines are better than long-acting ones in treating insomnia patients who tend to awaken during the night. We all know it's false. Why is that? You want to explain, Kendra? Exactly. Yeah. So you have a short-acting benzodiazepines, and you have a long-acting ones, right? And insomnia. Insomnia, there are two kinds. Well, I shouldn't really talk much about the clinical, definition of insomnia, but just generally, it's either people not able to fall asleep, okay, or they wake asleep in the middle of the night more often, okay. So they're like, depending on the case, if someone is not able to fall asleep, but once they do, they sleep the rest of the night, then which one do you wanna give? You want to give a short act or a long act? A short act, and hopefully one with rapid onset of action, right? But if someone falls asleep easily, but then they are continuously waking up in the middle of the night, then you want to give something that has long duration of action, right? Make sense? Yes, ma'am.
The question is for Ambien. It said it's for sleep maintenance. I mean, it's got a half-life of 2.5 hours. I'm just not sure.
Okay, that's a good point. Excellent point, actually. So half-life of 2.5 hours. So how long does it take for the body to get rid of the drug? 5 to 7, but that's to be completely out of the system, right? But there's a therapeutic window, so it's probably going to be out of the body. I mean, the effect will be out, the therapeutic effect will be out as soon as the concentration goes below the minimum therapeutic concentration, which is, I'm not sure how much, but just because you have a half-life of 2.5 hours does not mean that its duration of action is 2.5 hours. Let me explain this. Okay, sleep maintenance to me sounds like you have no problem falling asleep, or let's say you wake up, you have problems waking up, you wake up in the middle of the night. Okay, so you wake up during the night. So basically, drugs, or these drugs, which are actually the best ones to help, falling asleep. They have, some of them have short duration of action, some have longer, other ones have longer. So that's like, think of them are like 3 different categories. So the Ambien actually is one of the middle ones. There's one that has a shorter, I think it's, which one? Sonata, I think. Sonata is the shorter duration of action, so that would help you fall asleep. But then Ambien has a longer, but there is also another one, I think Lanista has the longest duration of action. Now for Ambien, those who made Ambien to compete with the Lanista, guess what they did? Extended release Ambien. Okay, you have Ambien CR, right? Anyway, so you got the idea of the duration of action, but as far as the half-life, this is a very good question. So, if this is drug concentration, and this is the therapeutic window, right? So drug goes up and then goes down. So the 2.5 hours mean if you're here, it would take 2.5 hours to get half the way through. It does not mean that the blood is completely out of the system. Yet, the 5 to 7 half-lives means that the drug is completely out of the system, or when you say completely, you refer to 95 to 99%. But for the drug to lose its effect, it does not have to be completely eliminated. It just has to drop underneath here. Make sense? Got this, everyone? Thank you for asking this question. Good? Yes, Maria. Of course. Yeah, they are yes, they are correlated. So yeah, if you have a half-life longer, then you have a longer duration of action. But I was trying to address the question of, so 2.5 half-lives, how is that a long duration of action? Well, half-life only gives you an idea of how long the drug, how much it takes the drug to be eliminated out of the body. But to find out how much is the duration of action, it's not only half-life, it's related to half-life. It's correlated with half-life. So longer half-lives mean longer duration of action, but it's not equal to T half-life. So duration of action is not equal to T half-life. Say it again. So short duration of action means, again, short half-life, okay? So it's correlated with half-life. I guess the question was, you know, half-life is 2.5 hours. How you would consider this duration of action to be long? Well, the answer is duration of action is not equal to half-life. Duration of action is correlated with the half-life, but it's actually longer than the T half-life, okay? So T half-life will tell you that drug will drop within 2.5 hours, it'll drop into 50%, right? But it's not completely out of the body. So it will take another half-life to get another 50%. And depending on the therapeutic window, if the drug is still within the therapeutic window, above the minimum concentration, effective concentration, then it's still gonna produce the effect. Okay? Melody?
Anyone who doesn't understand half-life, you draw it on a number line or just look up Google like half-life equating to a number line, I think it'll help. But also, and correct me if I'm wrong, but doesn't, besides half-life, the duration of action is gonna have to do with how it interacts with the receptor.
Yes, but remember the half-life impacts the duration of action more unless the drug binds irreversibly to the receptor, okay? So keep that in mind. So at the level of the receptor, you know, drug binds and leave. So yes, if it binds longer, it gives you, you know, more duration of action. But the highest impact would be how long is the drug above the minimum therapeutic concentration. The only exception is if the drug binds to the receptor or the enzyme irreversibly, like we'll see, then no matter how much the drug is in the circulation, if it's bind to the receptor, it's blocking it forever until new generation of receptors are coming out. Because, you know, proteins are always replaced by other ones, enzymes are always, you know, replaced by newer ones.
So anything over 50%.
That's a good question. So how do I know what's the minimum therapeutic? What's the minimum therapeutic concentration for drugs? So what is the minimum therapeutic concentration for a drug? It's the least amount, yeah, not the definition, it's the least amount, but is it like 50% of the maximum concentration I could achieve, or? It depends on the drug, thank you. Common sense, right? It depends on the drug. Some drugs might have minimum therapeutic concentration that are high, so you should administer a large amount of the drugs. Others might need low concentrations, so it really depends on the drug. Also, the window itself, remember? The window could be wide, you know, large window or narrow window, okay? So it really depends on the drug. And you should know the narrow therapeutic drugs by heart, the anti-Is, you should know them by heart because these are important anytime you have a drug interaction. If it affects one of these anti-Is, then everything freezes and you stop and you know, think carefully about what is the next step to do. That's why I spent a lot of time on the basics, because these will help you throughout, not just this session, but all the way until you graduate, okay? So please make sure you review these, well, not just for the final, but they will help you in understanding the differences between drugs, okay? And if you forget something or something does not make sense, I'll be glad to explain it again. So please don't hesitate to ask. I assume that these are covered, so I just, move to the next step, but then if you're missing something, let me know, okay? Good questions, right? Any more good questions? I mean, every question is a good question, so. No? Okay. Next one. Benzodiazepines are negative allosteric modulators for GABA receptor. We all know it's false. They are actually positive allosteric modulators. Okay. Which one? Thank you. So there is an example of a drug that is called neutral allosteric modulator or zero allosteric modulator or antagonist. Can you name this drug? I have to cheat. Flumazenil. Okay. It's a neutralizing. So how is this drug useful? Antidote, right? So if you get overdose of that benzodiazepine, then this drug will actually displace the allosteric binding site. Now remember, if this is the GABA receptor, I will show you in a graph. Maybe I should actually move to the last question since we were talking about this, okay? So benzodiazepines with, no, this one. No, sorry. Number 5. There we go. Okay, so which statement is most correct? Benzodiazepines bind to a different binding site on the GABA receptor than barbiturates. We all get this correct, I hope. Barbiturates are safer to use than benzodiazepine. Is this right? No. Which one is safer? In fact, it used to be they used to use barbiturates, for the help people sleep and all that. But then when benzodiazepines came out, they stopped using barbiturates. So why is benzodiazepines better? Safer? We don't know that it's safer because at higher dosages, you don't get the effect you get from barbiturates. In fact, barbiturates can take you into anesthesia, right? So actually, depending on the dose of the barbiturates, it could cause, relieve the anxiety and then sleep, and then it could actually send you to a coma, okay? So they could be used as anesthetic drugs in surgeries and, okay? Anyway, so benzodiazepines are much safer. They bind to different allosteric sites. So they both bind to allosteric sites at the receptor, at the GABA receptor. But they are different sites than the site of, what is the active site for the GABA? So the alpha is actually an allosteric site, but what is the natural substance that binds to GABA? GABA itself, right? GABA receptor, GABA, thank you, yeah. So GABA receptor, I want to show you this. Okay, so this is GABA receptor, okay? This is the natural endogenous messenger, GABA. This is the binding site for it, okay? And this is the binding site for the barbiturates, okay? This is the binding sites for benzodiazepines. Notice that they are separate, different from each other, okay? There are allosteric sites, but they are located differently. And there is other molecules like steroids. This is are actually neural steroids, not the hormonal steroids, okay? There are some steroids that are known as neural steroids. They bind to places like this. And there is something called bicrotoxin, which is another molecule that binds allosterically here. Now, the benzodiazepines bind outside at the alpha. I believe this, is it a gamma? I think it should be alpha. Anyway, so I'm just trying to show you how they bind to different sites. So that's the active site. This is benzodiazepine allosteric site. This is barbiturates binding site. The benzodiazepine actually, as positive allosteric modulators, they stimulate, they enhance the potency of GABA to bind to its active site. So they are called potentiators, okay? Positive allosteric modulators that are potentiators. So the GABA receptor becomes more sensitive to the GABA. As soon as the GABA binds, even a small amount of the GABA will be enough to cause, in the presence of benzodiazepine, will be enough to cause the chloride ions to get inside. And then what happens to the difference in the charge around the membrane when the chloride ions gets inside? Hyperpolarization, so it'll be difficult to stimulate the neuron, and then basically you cause sedation or anti-anxiety, okay? Barbiturates, on the other hand, they bind at a different binding site. They actually enhance, they increase the pore, they increase the size of the pore such that more chloride ions are allowed to enter. Not only that, barbiturates at higher dosages, they will be able to work alone without the presence of the GABA, the endogenous molecule, okay? In benzodiazepines, they cannot work alone. So they actually enhance the activity of GABA, okay? Well, we already have GABA in our body, so that's not a big issue, right? We already have the GABA as a neurotransmitter. So as soon as we increase the sensitivity for these receptors, then we're good. But it just, it's good to know that barbiturates, are, more efficacious. They have ability to give you more effect than benzodiazepines, which is the reason why if you have higher dosages of the GABA, then, of the barbiturates, then you get into anesthesia, which is not the case with benzodiazepines. Okay, so I'm trying to put everything together as far as the allosteric binding site. Binding to GABA and flomezanil. Where is the binding site for the flomezanil? Flomezanil, huh? Same as benzodiazepine. So if you have toxicity from benzodiazepine, so you administer an antagonist, right? Which is going to bind here and hopefully have a higher affinity than the benzodiazepine that's causing toxicity. And then it's just going to bind to that benzodiazepine allosteric binding site and do nothing, right? It's a neutralizing, or just like an antagonist. It binds and blocks the site. Remember the difference between agonist, antagonist, inverse, and all this? Remember? So with the antagonist, they block the binding site such that benzodiazepines cannot bind anymore. Okay, questions? Which one? The flumenazole? Okay, so what's the difference between positive and negative, first of all? Right, so positive means they are going to enhance the function of the receptor when the GABA binds, okay? So they enhance, so you have more chlorine ion getting inside. Positive. Now, negative means it's going to affect the GABA receptor. It's going to, reduce the activity of the GABA receptor. Flumenazole is actually not a positive, it's not a negative, it's a neutralizing. It means it has a zero effect on the GABA receptor, but it binds on the same binding site of the benzodiazepine. So it's like an antagonist. It's like an allosteric antagonist, okay? So it blocks the benzodiazepine from binding to the receptor, and the receptor resumes its normal activity. So it's used as an antidote. Yes. Yes. Yeah, yeah. I know. In the text they have examples of drugs that are negative allosteric modulators. Okay, but these examples are not, anti-anxiety indications, right? Because they would oppose the action of benzodiazepines. Make sense? Which one? Also, so that's a good one. So all these non-benzodiazepine, zolpidem, they actually bind also at the same binding site of the benzodiazepine. Okay, so they are non-benzodiazepines because they have a different class category, but they bind to the same alpha subunits at the GABA receptor. So that's a good question. Thank you. So the zolpidem and zol, whatever these, we call them the Z drugs. Okay, so which are mainly used for insomnia. They actually bind to the same binding site of benzodiazepine of the receptor. Z drugs, yes, I think there are 3 of them. Zolpidem and what are the other 2? Yeah, they all start with a Z. I know the brand names better, like Ambien, Sonata, Lonesta. Anyway, so you can find them. Next, yes, sir. What do you think? Barbiturates are positive, right? Okay. Okay, let's go to the next question now. Which antidepressants are most commonly used? We all know it's the SSRI, but why is that? Well, first of all, are these antidepressants benzodiazepine and melatonin? No, they are actually anti-anxiety, right? So, I mean, they might be used for someone who has depression because anxiety sometimes is the cause of depression, but then it's not classified as antidepressant. So we have the monoamine oxidase inhibitor, tricyclic antidepressant, and the SSRI. So why are the SSRI the best or the most commonly used? Fewer side effects. They have less side effects than the tricyclic and monoamine oxidase. So what's the advantage of what's the disadvantage of using monoamine oxidase? Question number 6, right? First of all, most of them bind to.
What's the name of that thing? It's like a storm or something that happens if you take. It's like a big warning on a lot of the medicines like this. SSRIs don't take.
Black box warning.
Yeah. What is it called when you take monoamine oxidase with SSRIs and stuff?
No, it's the hypertensive crisis. Okay.
That's what.
Yeah.
Sorry, I just.
Oh, no, that's a good point. So, we're talking about the best antidepressants, and then we all agree it's the SSRI. They are most commonly used. Now, why are they the best SSRI? I mean, why they are the best antidepressants? Well, first of all, compared to the tricyclic antidepressants, tricyclic causes, what side effect do they cause? It's anticholinergic. Thank you. They cause anticholinergic, or to be more specific, antimuscarinic side effects, which are, what are the anticholinergic side effects? Thank you. Can't pee, can't see, can't spit, can't shit, right? Never forget these. So they cause these side effects, anticholinergic side effects, okay? The SSRI, can they cause these effects? They can, but they have less frequency of causing these effects. They actually cause less efficacy. They cause less effect on the, they have less anticholinergic effect, okay? The SSRI. So comparing tricyclic antidepressant with the SSRI, tricyclic causes more of the anticholinergic. The SSRI causes less anticholinergic. Okay. What about, so why are the SSRI better than the monoamine oxidase, or what's the problem with the monoamine oxidase? First of all, if we have non-selective, they're gonna bind to monoamine oxidase A, monoamine oxidase B. A is in the brain, which is preferred. B is in the liver. When it binds to B, it blocks B. It's not able to metabolize cheese products. So you get one of the chemical, I can't remember its name, but it actually causes hypertensive crisis, okay? So if you take MO inhibitor, you should not eat anything that has cheese, which is horrible, right? For some people. So that's as far as selectivity. Second, if it binds to these enzymes, these drugs, they bind irreversibly to the enzymes, and it's dangerous whenever you have something that binds irreversibly, because first, if you want to stop the drug and switch to another one, you have to wait 40 days. If you get a side effect or toxicity, again, you have to wait for that long. If you ever take another drug that interacts with these monoamine oxidase, then you cannot just give that drug again. You have to wait 14 days before you give another one. So the irreversibility. Okay, and then what was the third one? Non-selectivity, the irreversibility. I think that's all, right? The hypertensive crisis has to do with the non-selectivity, which mean they block monoamine oxidase B. Now, do you remember in the anti-Parkinson, we also use monoamine oxidase, but the dopamine is actually metabolized by the monoamine oxidase B. Okay, let me write this down because I think it's worth it. Okay, so this is used for anti-Parkinson, and this one is used for anti-depression. Okay, so this one metabolizes dopamine. This one metabolizes norepinephrine and serotonin. Okay, make sense? This one also metabolizes, let's say, cheese in the liver. So this is CNS, inside the CNS brain. This is CNS. I'll give you a minute to write this because I think. Okay. So we have two enzymes, MAO, A and B. Okay, so B metabolizes norepinephrine and serotonin, which are the ones that are, good for depression. A. I'm sorry. A as in Adam metabolizes norepinephrine and serotonin. So if you inhibit this enzyme, that's good. You get the antidepressant effect. B as in boy, B as in David, I mean. You always hear it in the phone like, B as in David, you're like, what? Yeah. So B as in boy inhibits the metabolism of dopamine in the brain, and in the liver, it inhibits the metabolism of cheese. So if you block B, in the CNS, it's good, you get anti-Parkinson, but then in the liver, it's gonna cause problems which we define as hypertensive crisis. Okay, so agitation, increase in blood pressure, anxiety, and all that. If you block B as in boy. Say the whole thing again. Okay. Yes. Say it again. What's the underlined one? Okay. Let me actually write it in a nice way and send it to you, okay? Okay. But for now, we have A and B, okay? A metabolizes serotonin, norepinephrine. B metabolizes dopamine. Remember Parkinson? Dopamine and the cheese. Okay. So if you stop B, it's good. You get treatment for anti-Parkinson, but you end up with hypertension crisis. If you inhibit A, you treat antidepressants. Problem is, monoamine inhibitors, some of them are non-selective. They inhibit both. Okay. I will write it in a nice way in an email, in a PowerPoint, and send it to you. Okay. Some of you had the questions. I had to ask them to wait. Did I answer the question? All right. John, did you have a question? No? Okay. Okay. Melody, did you have a question? You're good. Did anybody has a question that I asked him to wait? Yeah, Daniel? Excellent. So we actually have some drugs that bind reversibly, not irreversibly. These are available. They bind to monoamine oxidase B, okay, and they are used for anti-Parkinson, but the problem is with their side effects, okay? So, but for the A, we have ones that bind reversibly, but they are not in market in the United States. The one we have in US that inhibits the monoamine oxidase A, unfortunately bind irreversibly. So you might think, why don't we bring in market the reversible ones? Well, we have better options. Why even bother deal with the monoamine oxidase inhibitors? So they are rarely used actually, okay? You will rarely see examples of these as antidepressants. Exactly. So if we have a reversible, then you don't have to worry about the 14 days. Thank you. Guys, that's a good one. So if you have, and if you pick a reversible monoamine oxidase inhibitor, which is available in market only for anti-Parkinson, and they bind to the monoamine oxidase B, as in boy, these, you don't have to wait for 14 days. You just have to, wait. How many to get for the drug to get out of our body? 5 to 7 T half-life of that drug. Okay. Depending on how picky you are, you want the drug to be 95% out of the body or 99%. So it's between 5 and 7. Everybody get that? Thank you. So now, ideally, if you want to treat Parkinson, hopefully, you need the drug to bind the monoamine oxidase in the CNS and not reach the liver, but that's difficult because eventually the drug will reach the liver anyway. Okay, so we do have reversible monoamine oxidase inhibitors that are used for anti-Parkinson, okay, and they are selective. So why do we use these drugs if they have these effects? Well, first, they're reversible, so they're not as bad. Okay. Second, yes, you will get the cheese toxicity because of cheese, but again, when it comes to when you don't have much options, then dealing with not eating cheese or Parkinson. Okay. But when you come to antidepressants, we have plenty of options. We have SSRIs working wonderfully. We don't have to worry about any of the side effects. So why even think or consider about monoamine oxidase. That's why they didn't even bother bringing the reversible in the market, because we don't need it anyway, right? We had the irreversible one and we don't use it. So anyway, it's like bringing something and try to compete with the market when you have better options. It's like waste. Make sense, guys? Does everything make sense so far? Number 6? Okay. I can't remember which question are we at now. Okay, we'll get to 6, but let's first try, see, we make sure we cover. So we got 1, we got number 2 and number 5 together, right? Allosteric modulators. And then we got number 3 and number 7 together, because we compared why is the SSRI best or most commonly used. We already know that the side effect for tricyclic is more anticholinergic. Okay, you already got that. And let's see, so we're left with number 4, 6, and 8. Okay, so number 4. Oh, we already answered this one before the class. It's like a giveaway question, right? So why do we have to wait for 2 weeks? Because of the receptors being desensitized, okay? And I had to come up with these ideas, being creative, right? Anyway, number 6. Okay, so that's your question, Dania. Why should we wait 14 days before switching from monoamine oxidase inhibitor antidepressants to another? Because it takes antidepressants 14 to start working? No. Because they have long half-lives and might take 14 days to be eliminated. It depends on their half-lives. So that's the one that got you tricked, right? Well, you're out of luck, I'm sorry. And then monoamine oxidase now are lipophilic drugs that are stored in fat tissues, and they are metabolized to the active form, and the irreversibly is the right one. So we all know it's E. Now, I just want to comment, I mean, I already mentioned that if the half-life is, long and you have to wait 5 to 7 half-lives, then you have to do the math. But with the case of the reversible, I don't think it's the case. I think their short lives is reasonable. So within only a few days, you can be out. I have to say that these sentences, as far as lipophilicity and metabolized to the active form, are actually correct conceptually, but they do not apply to the monoamine oxidase inhibitors. In other way, if a drug is lipophilic, yes, it will stay longer in the body because it will bind to the fat tissues, and then eventually it will be released slowly, so you have a longer duration of action, which is one way of increasing the duration of action for a drug. Okay, so conceptually, number C is correct, except it's not the case with the monoamine oxidase inhibitor. The same with number D. If a drug is metabolized and gives you another form that is active, guess what? This active form or metabolite will continue to produce the therapeutic effects. And so you will have longer duration of action, which is one mechanism of designing long-acting drugs, by making them producing an active metabolite, which is actually the case with the long-acting benzodiazepines. If you have noticed in those benzodiazepines, many of them are converted into active metabolites, and that's how their duration of action is long. Okay, so one time we mentioned we need to have a long duration of action for benzodiazepines. Another, we said we wanted to have short duration of action. Which ones are preferred? Long ones? What if you're trying to help someone sleep? So the answer is, it depends, okay? If you want somebody to help sleep, again, we have very short ones just to help them fall asleep. If somebody has problem waking up at night, then you have some ones that work for like 6 to 8 hours. If someone has anxiety, then you just want to treat his anxiety half the day and then let them deal with it the rest of the day? No, that would be mean. So you need to use something that has a long duration of action to work for the whole day, right? Okay? So we have all these options available for us. Questions? Yes, ma'am. Yes, the case, exactly. Why say it again? Why is question number one false? I see your point. So if it depends on the case, well, because I defined that someone who's awakened at night, and I was referring to the options of those that have short or long duration. So if you are trying to help someone maintain their sleep, then you want to give them longer duration compared to short. Okay. So okay. I know you need a break, but this is the last one here. I promise we'll have a break. Okay, so benzodiazepines, this is, again, we just explained, with longer duration action, well, benzodiazepines with active metabolites have longer duration of action than those with inactive metabolites. We all know it's true. Again, this is actually one way of increasing the duration of action of drug, okay? You can either make it more lipophilic, or you could design it in a way when it's metabolized, it actually gives you an active metabolite, which is actually very challenging because there is no way to predict how enzymes in our body work, which one is gonna have. So it's hard. So normally you do experiment, you collect the metabolites from the urine, assuming the drug is eliminated in the urine, and then you test these metabolites, see which one is active, and then you decide if it's going to have a longer duration of action or not. Or, so that's experimentally, and then later on, eventually, you're going to try it on, animals, and then later on, clinical phases on human. Clear, everybody? Any questions so far? Yes, Kevin.
So, antidepressants take 2 weeks to start working?
Yes.
Why don't the central sympathomimetics take 2 weeks to start working?
Yeah. I mean, that's a very good question. So not only the central sympathomimetics, but generally drugs that work centrally. Why do we not face the same challenge? Okay, which is we have to wait for 2 to 3 weeks. And honestly, we don't know the answer. In fact, the theory of the desensitization is just a theory. It's not been proved. Okay, I wanted to stress out this fact and have you struggle with the why does it take 2 to 3 weeks, because when you struggle with something, you stick forever. Okay, so the truth is we are not sure if this is the main reason, which is desensitization. So the desensitization is just a theory that is proposed that we think it's the reason, but we're not sure if it's really the case. Thank you so much. But I wanted to ask the question, why does it take 2 to 3 weeks, such that you actually struggle, and then when you struggle, you memorize it forever, hopefully. Because I think it's an important fact. As a pharmacist, like I said, you have 2 scenarios. You will see people coming back within a few days, tell you, it does not work, and you'll see people coming back or not refilling their prescription after a month because they think, I'm doing good. I don't need this medication, right? So that's important to, as a pharmacist, to keep in mind that these drugs take this long, and you want to be able to handle both cases of those who decide to quit and those who decide to quit after they feel good. Any questions before we take the break? No questions? Okay, 7.5 minutes break. So yeah, so be back at 10:20. Yes. Okay, guys, let's go ahead and start with the applications. The first one talks about comparing between the binding sites. Well, we covered this already, don't we? So the binding sites for the benzodiazepine, non-benzodiazepines, barbiturates, and relate this to the flumazenil. We covered that already, okay? So we do know that there is active site for the GABA, there is allosteric site for the benzo, there is allosteric site for the barbiturates, okay? And for the benzo, we have positive allosteric modulators, we have negative allosteric modulators, we have neutralizing or zero allosteric modulators, or you can call them antagonists. So let's go to the exercise number 2, the SAR for the benzodiazepines. So I'm just going to show you where this is the page that has the SAR for the benzodiazepines. Study this page, okay? And hopefully we're going to have someone to come here and explain this SAR for us and how these changes in the structure affects activity, duration of action, metabolism, and all that together, okay? This is probably the exercise that's going to take the longest. I think the other ones should be straightforward. Okay, so exercise number 2, we'll start discussion, let's say at 10:35, okay?
Okay, so I just have a quick question.
Sure.
Hypnotic.
Okay, so are you guys ready? Somebody said no. Ready? The same person said yes. You guys are confusing me. All right, ready? Okay, assume you're ready. So starting with volunteers. Volunteers, please don't force me to get my random number generator. Okay, so what is the effect of adding an electron withdrawing group at position number 7? It increases activity, right? So can you give me examples of electron withdrawing groups at position number 7? Chlorine, fluorine, all these are electron withdrawing groups. If you look at the structures, all of them have these, not all of them, but many of them have the chlorine, fluorine, which is increasing their activity, okay? And to start with, by the way, guys, these two rings, A and B, are known as the benzodiazepine. So ring A is the benzo, ring B is the diazepine because it has 2 nitrogens, diazepine, and it's how many? 2, 4, 6, 7, 7 atoms ring, 7-member ring. So one of the questions someone asked me is if non-benzodiazepines bind to the same allosteric site as the benzodiazepine, why do we call them non-benzodiazepine? Well, first of all, the allosteric site for benzodiazepine was named after the benzodiazepine before we even know that there's non-benzodiazepine, okay? So we had benzodiazepines, it binds to this site, so we named that site after benzodiazepines. Later on, we find other drugs that do not have this nucleus. They do not share the same structure. They have a totally different structures, okay? These zolpidem and all the Z drugs. So they are not benzodiazepine, but they bind to the same allosteric site of the benzodiazepine, okay? So do not get confused. The structure itself is different. They're not benzodiazepine as far as structure, but they bind to the same allosteric site, okay? Make sense? Okay, and let's see. So at the ring C, if you add a phenyl group at position number 5, I'm sorry, if you add electron withdrawing group at position number 2 or 6, it increases the activity. We all agree? Can you look at the structures? Give me a name of a drug that has an electron withdrawing group at position number 2 prime. I think there is one that has a chlorine there. Which one? Say again. Flurazepam. Okay, so if you look at the structure of flurazepam, it has, is it chlorine or fluorine? Yeah, fluorine at 2 prime. So that would increase the activity. Now, if you have a substitution at 4 prime, what happens to the activity? It decreases. And then you have 2 arrows, which means it decreases like twice. Now, normally, I would like to know the structure of the receptor and tell you why if you add this, this happens, why if you add that, this happens. But because we do not have the structure of the GABA receptor, as far as I know, so it's like a black box to it, for us. So we modify something and then we test it and then come out positive or negative and then we report it, right? It's like trial and error. But if I know the receptor, then I might be able to explain better and say, okay, I need an electron withdrawing group here to do this and that and bind to the receptor in a better way. But we don't have this, okay? In fact, I think the structure, the X-ray crystal structure of the gabapentin has been released recently within a few years. But I don't think the studies are up to date on how these drugs bind to them. This is one of the problems with with receptors that are membrane bound, okay? Because as soon as you take them off the membrane or you synthesize them outside the membrane, they have a different conformation, and then you cannot tell which conformation is the active one, which conformation the drug binds to, and it's complicated. Anyway, so back to our SAR. Let's see. So at position, so the R group here, nitrogen at position number 1, the NR group is optimal for activity, which means if you try to substitute the nitrogen here with an oxygen or a carbon or anything else, it's not good, okay? So this is optimal for activity. And then what else? We have hydrogen accepting group here with increased activity, which is position number 2. Carbonyl is a hydrogen accepting group. Important for activity. Now this could be fused with another part, another ring, and then we have 3 rings fused together. It would be called I think triazolam was one of the drugs. Something. Can someone help me? Triazolam. There's a drug that has 3 rings fused and starts with tri. I'm not, I'm not supposed to know it. You're supposed to know the name, not me. Yeah, you should know. No. So you should never, you will see that you should never memorize an SAR. You should be able to use it. So you'll be presented with this figure, and then you'll be given structures, and then you should know whether that structure is active or inactive. You should be able to use it, yes. So, okay. Which should be fun, right? I mean, you have like instructions and you just follow the instructions, right? Anyways, yeah. Oh, optimal activity, like, the highest activity or the best activity, okay? So if you change this, then activity drops, okay? Okay, so now the fun part here, 2, 3, and 4, substitution, or actually mainly number 3, I'm sorry. So substitution with an OH group here would maintain the activity. Now, without OH group, it would stay polar, it will be converted to the active metabolite. It will be glucurinated, you will have loss of activity. And then without OH, with an OH here, without an OH, non-polar, I'm confusing you, I know, I'm trying to undergo hepatic oxidation and active metabolites. Increase reaction. Okay, so remember the example of the hanger? The hanger that we did, the hangers. Okay, so we had one hanger that represents what? Like an OH group, right? And then we have the 6 hangers put together to make the glucuronide. So phase 1 was basically adding 1 hanger, right? Phase 2 was attaching a glucuronide to the hanger, right? So if you do not have this hanger, then the drug would first have to go through phase 1, okay? Get metabolized. And the good thing is, when you have an OH group here, the activity remains. So you add 1 hanger, that's phase 1. The drug is active or inactive? It's active. Now, one of the questions someone asked me was, well, if it's metabolized, why is it still active? Well, think of activity as the pharmacophoric groups. If none of these pharmacophoric groups are affected, the drug is still going to be able to bind to the receptor. If one of these pharmacophoric groups is affected by metabolism and the new functional group is not able to bind to the receptor, then the drug loses its activity. Make sense? Okay. Normally, when the drug is metabolized, it affects the structure, the pharmacophoric groups, and it's inactive. But in some cases, like here, at position number 3, whether you have an OH or no OH group, both are active. So this part is not important for, it's not affecting the pharmacophoric groups. So you add an OH group, activity remains, and the drug now is still active, okay? So without an OH group, the drug will produce, will give you the activity, and then it goes through phase 1, it's metabolized, the metabolite is active, it has an OH, it's holding one hanger now, it has an OH group, and it circulates again, okay? It circulates again and it produces the effect, and then goes to the liver and gets the 6 hangers together, glucuronides. Now it's inactive. So what happened to the duration of action? It increases duration of action, okay? So the drug now has produced an effect without an OH group, and then it's metabolized phase 1, and then it produces another effect for a second round, and then it's metabolized phase 2, and then it's excreted. What if I give the drug already with an OH group? Have I facilitated the metabolism or not? If I give the drug, administer the drug with an OH group, it's like I'm giving the liver a favor, right? It's like somebody come in with the hanger already, I'm ready to be metabolized. Just take me to phase 2 immediately, right? So then the drug is metabolized and the duration of action is short. Make sense? Right. Questions? You still have question, Maria? No? Right. Yes, ma'am. Okay, so first of all, whether you have an OH group at position 3 or you don't, the drug is active. Why? Because it still has the required pharmacophoric groups. They are not being affected by the presence of the OH. The drug is active, and the activity is actually the same, whether you have OH group or not. So you get the same level of activity, okay? That's what this, this is the arrow here means. So the activity stays the same, okay? It's not up or down, it's just equal. With an OH or without, it's equal. The only difference is, if you do not have an OH group, then the liver has to work to add the OH group. So it's buying time. So now the liver will add the OH group, but the drug is still active, right? So the drug can still produce more effect. It takes another round in the circulation and produces more effect, and then goes back again to the liver. Now the liver will take it to phase 2 and add the glucuronic acid, the 6 hangers together. And now the drug is not active, it's metabolized. Okay. Now, if you already administer a drug, design it in a way it already has an OH, okay, and then you have saved the liver the work of adding an OH group. So now when the drug reaches the liver, it's ready to be metabolized to phase 2. And it is metabolized immediately, so I have a shorter duration of action. So the effect of an OH group on the duration of action. Is that clear, guys? If you got this 100%, can you raise your hand? Okay, great. Right. So the second thing I want to talk about is the, so we have talked about the ease of metabolism, okay? The effect of the ease of metabolism. Now we have the effect of lipophilicity on the onset of action and the duration of action, okay? So first of all, if the drug is modified in a way that is more lipophilic, would you think it would have a fast onset of action or slow? Fast. Why is that? It could cross the blood-brain barrier faster, okay? Now, what's the shocking news is this same drug, when it's more lipophilic, normally when a drug is more lipophilic, what happens to the duration of action? Longer. Guess what? With these drugs, benzodiazepines, barbiturates, when they are more lipophilic, yes, they will have fast onset and produce the effect in the brain. But what happens is the drug, because it's more lipophilic, they will be distributed to the fatty tissues. So they will leave the brain faster because they are lipophilic, and they will be distributed in the other fatty tissues, so the duration of action would be shorter. The reason is the redistribution of these drugs back into the fatty tissues. Now, if the drug acts on other parts other than the brain, then the fact that it's more lipophilic means the drug stays longer in the body and will give more effect. Okay. Now, because it works in the brain, first it crosses the blood-brain barrier, gives you the effect, but it's redistributed again to the fatty tissues. It drops from the brain, so the duration of action would be shorter. Okay. I know this is tricky because normally when you increase the lipophilicity, the drug will have longer duration of action. But it's because the drug is, being redistributed out of the brain to the other fatty tissues. Now, in case if you are wondering what happens to these drugs that are bound to the fatty tissues, once the drug is out of the brain and being eliminated, now they are being excreted. So you will have something called residual effect, okay? So these benzodiazepines, okay, they have something called residual effect, which means, you're not sleepy, but you're not fully awake because of this effect of the drug being released slowly now, okay? So your goal, if depending on what you need really, if you need, long duration of action and treat anxiety, yes, that's good. You have long duration of action. These residual effects are good. The person is being calmed down. But if you try to help someone, fall asleep, but wake up, energetic and fresh and, with no any effect, then you should go with the Z, non-benzodiazepine drugs, because these drugs, they will work for a short amount of time, produce, help you sleep, and then, you're fresh and awake in the morning. And I want to point out that these drugs, actually, you should advise the patient, if they take these drugs, they are very potent. They will make you fall asleep. So if they take this drug, they should be ready with it to be in bed immediately, because if they resist, weird things happen, like, like hallucinations or seeing strange things. So if you plan to sleep, then you go to sleep within that time. Avoid, having visitors or staying up or something. If something else happened, then, that's a problem. Okay. It's not like the benzodiazepines that help you being sedative. If you decide to go to sleep, yes. If not, then you could resist and you'll be fine. But with the other drugs, you cannot do that. Okay, I know you have a question additional. No, was answered. And somebody else has, yes, ma'am, Tanya. Okay, so in cases the drug acts outside the brain, so when you have a drug that's more lipophilic, then the drug will stay longer in the body, okay? But also remember that it also has to do with how much of the drug is above the therapeutic effect, okay? So if the drug is lipophilic, it distributes to the fatty tissues, and then if it's being released back from the fatty tissues and you have enough of the drug to be above the therapeutic effect, then yes, you will have longer duration of action, okay? So, you wanna consider all these factors. Now, luckily, you don't have to decide how much is the duration of action of the drug. This is all will be given, right? I mean, we already know all these results already, but my goal is to explain to you how drugs work, why you see this drug has longer duration of action, why this has short, why this one is redistributed again, why this one is not. It's in its chemical nature and its lipophilicity. So that's why you learn these basic sciences. But later on, you're probably not going to care about why is it even have a long duration of action. Later on, you would look at the results and say, okay, so this drug has this duration of action. That's it. This is how much I want. This one has short duration of action. This one has long. But the knowledge or the basics behind why this one has long or short, this is what my job is, okay? I'm trying to explain to you. So you need to know this because it helps you as a pharmacist to, you know, if you ever want to analyze or rationalize, you know, predict something, then these basic knowledge will help you, okay? But, you know, your job would be much easier later on when you use your, what is it, your software. Yes, you have a question.
Back to what she was asking, did you say that upper velocity gives a shorter duration of action in the syndrome?
What do you think? Okay, I actually also thought it would be the opposite, but then when I thought about, you know, when I read the explanation, which is, yes, they stay in the body longer, but they are staying in the wrong side of the body. They're staying in the fatty tissues, not in the brain. So if they would stay in the brain long enough, then yes, they will have long duration of action. But what happens is, initially they go to the brain, but then they are slowly being they are actually being redistributed again. They leave the brain and go to the fatty tissues. So you will have a short duration of action, which is like, you know, I think that's the only exception I can think of. All the other drugs, normally we increase their lipophilicity to make them have long duration of action. Questions? Yes, sir. Oh, alcohol? Okay, very good question. So guys, alcohol also causes sedation. In fact, the other day we talked about its mechanism of action. It also binds to the GABA receptor. So administration of any of these drugs with alcohol is contraindicated. Why? Because you get more sedation than you want, okay? So that's a good one. I wanna show you the SIR for the barbiturates, because that's when lipophilicity actually, I mean, that's when the you will see more examples on differences. Okay. So this is the SIR for the barbiturates, okay? And it shows how, you know, increasing lipophilicity, yes, will give you a quick onset, but then shorter duration of action because of redistribution. Okay, when you, you know, modify certain groups. Now you will see examples on these alkyl groups. So if you look at these groups, they're actually all lipophilic. So how can you compare between two lipophilic groups? One of them is more lipophilic than the other. If you have a chain like this, for example, 1, 2, 3, 4, 5, and then you have another one, or let's say 6, okay? You have another one that's 1, 2, 3, 4, 5, 6, okay? The same number of carbon, both lipophilic, but one of them is more lipophilic than the other. One is branched, one is not. Why is this important? Mm-hmm. I'm talking about lipophilicity. Which one is more lipophilic, the branched or nuns? Not only that, but say you have another example of, you know, cyclohexane, and then another example of benzene. They both have the same number of carbons, right? One is saturated, one is not. Or you might have other groups with double bonds or not. All these are lipophilic. Anytime you have hydrogen and a carbon is lipophilic. But which one is more lipophilic? Which one? The branched is more lipophilic. Why? Stability. Well, I mean, this has nothing to do with stability. Okay, these are additional informations. If you are concerned, look it up, think about it. If you are so curious, you cannot find the answer, I can give you the answer, but I'm not going to give you the answer here. It's not going to be in the exam either, so. Okay, so this is just for fun. Okay, think about these groups. If they're all lipophilic, how can I compare between lipophilicity? Okay, yes, Cheryl. Less hydrogens? No. Yes, ma'am. Okay, but if you have the same number of carbon and you have a long chain versus branched chain, which one would be more lipophilic? No, it's not.
The longer, less branch is going to be more lipophilic
Less branches is more lipophilic. Why?
because it can van der Waal or something.
Okay, Van der Waal or something. Okay.
The lipids are that way. They can
I agree with what you're saying because there'll be, if it's straight chain, you have more carbon exposed and then they'll be able to find using by the wall plus with the carbon of the fat. And then it's more the, what's it called?
Lipophilic. Excellent, excellent. Good job. Yep, so the long chain ones compared to the branched, the long chain ones will have larger surface area. They are more able to expose and cause van der Waals interactions and, than the branched. The branched ones will have a smaller surface area, so they're not gonna be as lipophilic, okay? Kevin, you had something to add. Thank you so much, excellent. So that's the second factor, which is saturation. So we talked about two factors. One of them is branching, the other one is having a double bond or not. So the more double bond you have, the more double bonds you have, like if you have an aromatic or if you have double bond, then you have more electrons available, so it's less lipophilic, okay? So when you have bi bonds electrons, these electrons can change, the molecule can become polarized or depolarized easily. So, okay, so I'm glad you guys find the answers. Good job. Adishola and Kevin. Remind me to pay you at the end of the month, okay? My wife is gonna kill me, I know. Okay, so the branching one, when the chain is branched, it's like all the carbons are occupying smaller surface area. But when it's long, then the surface area is more. So surface area means that it's more lipophilic, okay? Yeah. Okay, so I hope you had fun so far. Let's move to the next exercise, which is, okay, compare between, this should be an easy one. Compare between the melatonin. Have you guys seen melatonin over the counter? Okay. So what is melatonin? It's a hormone. It's called the night hormone, right? Or the darkness hormone, I'm sorry. Darkness hormone, it's actually released as soon as the sun goes down. The hormone is released in the brain. I can't remember the name of the gland that it releases the hormone. Pineal gland, thank you. So the hormone is released and then helps you, fall asleep, okay? So that's why when you have this leg chat, if you travel, to the east, right? So you'll have problems falling asleep because the sun is not down yet, okay? So if you travel to the east, then one way to help you fall asleep is to take melatonin. Problem is, we have 2 or 3 different receptors, melatonin. And when you take melatonin, the one that's over the counter, first of all, it's not regulated by the FDA. It's just like all the other herbal drugs. One manufacturer might have a different amount of the melatonin, another might have a different absorption. All these factors is not regulated. So it's not selective and it's not as pure, okay? So guess what? One of the pharmaceutical companies decided to study this, look at the design a drug that is melatonin agonist, okay? And it is selective, so it only binds to the required receptor, okay? And not only that, it binds to a different receptor than, all these GABA and barbiturates, which is the melatonin receptor, of course. and the drug is called, the brand name is Rosarim. You help me with the generic name. What's the generic name? Huh? Rameltion. Thank you. Rameltion. This is the name of the generic name, which is a melatonin agonist that helps you with sleep. And it was actually a good thing because you don't have to worry about abuse. You know, all these medications that benzodiazepines, they could be abused. But then with this drug, you don't have to worry about abuse, okay? So Rosarim was the example. Any questions about this before we move to the next one? Any questions about the melatonin receptor? So is it a positive or negative allosteric modulator? Melatonin receptor agonists. Ramelton, is it positive or negative allosteric modulator to the GABA receptor? What? You've been checked already? So Ramelton, is it positive or negative allosteric modulator to the GABA receptor? It does not even bind to GABA receptors, right? It binds to the melatonin receptor. All right. Now I know how to put my questions on the exam. Okay. So, you know, benzodiazepine, non-benzodiazepine, barbiturates, they all work on the GABA receptor, but, you know, the Ramelton works on a different receptor. Okay, it works as an agonist, which is hard to design, right? I mean, antagonists are more easier to design. Okay, any questions about? Okay, so exercise number 4, impact of non-selectivity. Oh, we already talked about that, and I promise I'm gonna send you a nice handout, you know, visual explaining, you know, monoamine oxidase A and B, and you know, all this thing. Yes, yes, okay, yes, ma'am. Exercise number 5. Relate the difference in selectivity, reuptake inhibitor to their structure. Okay, so I'm not sure if you've seen that in the note, but it basically says that, you know, by, you know, the tricyclic antidepressants, from the name, they have tricyclic, right? And by splitting the cycles, these 2 cycles into 2 cycles, let me say it again. Tricyclic antidepressants, from the name, they have 3 cycles. Then when you split the one in the middle, right? Okay, that's not a good example. When you split down in the middle, okay, then you would have 2 rings, the same rings, okay, but now they bind to a different transporter and they block the absorption of norepinephrine and serotonin, okay? So basically, I just wanted to, you know, for you to compare these 2 structures and look how, you know, the tricyclic are 3 cycles together, and you remove the one in the middle, and then now you have 2 cycles are free to move, and just the fact that they have a different conformation, now they can actually bind to different transporter. So they act differently. That's everything about this exercise. So it's just really for fun. It's not. And then compare between the side effects, exercise number 6, side effects between tricyclic antidepressants and the SSRI. We have already talked about that, right? What is the difference between the SSRI and the tricyclic antidepressants? Which one has more yes, tricyclic has more anticholinergic effect than the other ones. There's a little side effect on the SSRI that is not on the, sorry about that. There's a little side effect on the SSRI. You know, I guess one disadvantage of the SSRI compared to the tricyclic. Can someone name it? Actually, that's a good side effect. But most of these drugs, unfortunately, cause you know, sexual dysfunction, right? But then if you are depressed, So which one is more important, right? But they actually go away with time. So antidepressants with time, these effects, they go away, just like the anticholinergic effects. They have dry mouth, right, and mydriasis. With time, these, good thing is these side effects, they go away. So dry mouth, mydriasis. Now, of course, it might change from one person to another. So that's why people, switch from one medication to another to actually find the best one that works for them, that has less side effects, okay? But, so the only disadvantage of the SSRI over the tricyclic antidepressants, they both cause sedation, but the SSRI causes more sedation, okay? So if sedation is an issue, then the antidepressants are recommended to be given what time in the day, morning or night? Night. If sedation issue, sometimes it's not. Okay, I think there is one more concept I wanted to share with you. Prozac. If someone has ever been taken, if a patient has been put on Prozac, then if you want to stop this drug and switch to something else, then it will take about, again, 2 to 3 weeks or maybe 4 weeks before you could switch to something else. Why is that? Well, if you don't, and you give, see, if you give these two drugs, combination of two drugs, MO inhibitor and SSRI, or two SSRIs, or any of combination of these, that then, that would have more of the serotonin, then you get the serotonin side effect. Now, in order to avoid that, with the MO inhibitor, you had to wait 14 days because enzymes would take 14 days to be resynthesized, okay? And because MO inhibitors bind irreversibly, okay? Now, with the Prozac, it's actually an SSRI. It does not bind irreversibly or anything. The reason we wait for that long time is, anybody want to guess? Lipophilicity, thank you. It has a long half-life. It's more lipophilic. It distributes in the tissue, and then it takes long time for the drug to be eliminated completely out of the body. So before you could switch from a drug like Prozac to something else, you have to, first you're gonna stop Prozac. You don't have to like cut the tablet into half, because if you just stop it by itself, it's gonna gradually go down, but then you're gonna administer the other drug also gradually, okay? So you wait for a week, don't take medication, any medication, no Prozac, no anything else. And then the next week, you give half the amount of the new drug. And then the third week, you give the full amount of the three drug. Make sense? So this is all, you're gonna learn about this later in clinical. I just wanted to relate, why do we wait this long in the case of the MO inhibitor? Because it's irreversible. In the case of the Prozac, because it's lipophilic. Okay, so I know you need a break probably, right? And then we'll come back and review what we had today and, continue as long as you want, okay? So let's take like another maybe 7.5 minutes. So come back and then we'll review today concepts. Has it been 7.5 minutes yet? Is everyone back? Can you, if you are not back, can you raise your hand? Okay, if you have something, if you have someone missing in your team, raise your hand. Okay, so let's wait like a few more minutes. Okay, so ready to start discussion? So I think I want to visit the lipophilicity thing and show you a figure that hopefully will make more sense. So it talks about the as we increase lipophilicity only for these barbiturates, benzodiazepines. Okay, this is an exception. Okay, by increasing lipophilicity, you have more onset, you have shorter duration of action. The reason is when the drug is administered in the blood, when it's more lipophilic, it penetrates the brain fast, so you have quick effect. But then because it's more lipophilic, it actually leaves the brain again and accumulates in the adipose tissue, and then it's cleared. okay? So only when you have drugs that work in the brain is when you see this effect. Other drugs that works outside the brain, as the molecule is more lipophilic, they get longer duration of action, okay? And then of course the opposite is true. If it's less lipophilic, it crosses the blood-brain barrier, but at slow rate, but then it stays there longer and before it actually goes to the adipose fatty tissue. So adipose tissue are fatty tissues, okay? So another graph that might compare the two is this one here. So you have very lipophilic, fast onset, but then they are quickly redistributed again outside the brain. You have less lipophilic, slowly onset, but then again, slowly redistribution. So you have larger duration of action. Yes, ma'am. Exactly, yes. Because the action of these drugs is in the brain. So as they leave the brain, they lose their action. So they have a shorter duration of action. Okay. I see you take pictures. I will share these with you, okay? Yes? Say it again. No? Okay. Questions about this part, guys? Lipophilicity and so you don't have to worry about these slides. I'll share them with you anyway, just for your own information, okay? Because I know you like to learn. Yes, ma'am. Yes. Yeah, that's a good. Yes. So if the drugs affects other parts of the body, then when the drugs are more lipophilic, they will, you know, stay outside, and then they will produce the effects. They will have a longer duration of action. But really, guys, you want to think of all the other factors. I mean, what if the drug is accumulating in the adipose tissue, but it's, you know, slowly releasing the drug back to the circulation, but not to the level where it's above the minimum therapeutic effect. So then again, you're not going to see the effect. So you want to keep in mind, some exceptions. So there are general rules when you say lipophilicity increase, duration of action increase. Exceptions would be, in this case, if it's in the brain. Another exception is if the drug, yes, it binds to the fatty tissues, but then when it's released, it's still not above the minimum therapeutic concentration, so it's not going to give you the effect either, right? So, I mean, these are just exceptions. And for the barbiturates, let's see. So these are some the SAR for the barbiturate that shows some of them, has a double bond, so it will be less lipophilic. But again, we don't have to worry about that for, as far as which one is double bond, and branch or non-branch. I just thought I will talk about this. Anyway, yeah, I will post this. It will be like for your own information, okay? You're welcome. Okay, another thing I believe you had some issues or questions with was this part here. Switch to DocuCam. Okay. So what does this look like? Brain? Thank you. It's like, this is like the worst brain ever. Okay, I'm glad you figured it out. Right. Brain, just in case. What about this? Huh? Liver? Thank you. You guys are nice. Because again, this is the worst liver ever. Liver ever. Okay. So in the brain, we have monoamine oxidase inhibitor. I mean, monoamine oxidase A and B, okay? In the liver, we only have B. Anyway, so when we try to treat depression, they inhibit A. Why is that? Why do they not inhibit B? I mean, why do we not want them to inhibit B? Because A is the one that metabolizes norepinephrine. B is the one that metabolizes dopamine. So when do we need less dopamine? I'm sorry, when do we need more dopamine? Okay, so in the case of Parkinson, we need more dopamine, so we inhibit this. We need more dopamine in the case of Parkinson, yes. So Parkinson, we have less dopamine, right? So we get the acetylcholine taken over Parkinson, okay? For when you have Parkinson, what do you think? So Parkinson, the disease Parkinson, do we have less or more dopamine when you have Parkinson? You have less dopamine, yes. Yes, so if you wanna treat Parkinson, okay. So to treat Parkinson, you block MAO-B metabolism, so you'll have more of the dopamine. Now, norepinephrine is metabolized by monoamine oxidase A, so we need more of the norepinephrine in the case of treating depression, so we block A. In the liver, cheese is metabolized by B. So if you block this, okay, you get hypertension. Okay, which is not fun. So these amines, the cheese, if they are not metabolized, I can't remember the name of the chemical that would, tyramine, thank you so much. So you have more tyramine, and then this causes, hypertension, confusion, delusions. Yes. Oh, hyper, I'm sorry.
I was reading that some of the inhibitors can be used for hypotensive.
Okay, like which inhibitors? The antidepressants? Okay. So if you inhibit MAO-B, so then you get more of the tyramine. I'm glad you mentioned the name, it's tyramine. You get more of the tyramine, and you get the hypertensive crisis. Okay. So in theory, if you design a drug that is selective on the MAO-A, right, then you don't have to worry about that. Okay. So in theory, you might be able to treat the depression with the monoamine oxidase inhibitors, the selective ones, and hopefully if you have the reversible one, so that would solve the problem. But again, even though sometimes we are selective to the A, one of the side effects would be that you could still inhibit the B, okay? Unless you have really super duper selective MAO inhibitor. Plus, when you have a good drug in the market like the SSRI, then it's hard to compete with them. So why would you try something else and try to convince people to prescribe this drug when you have something that's really good, okay? So that's why we don't even have the reversible MOA inhibitors in the market. On the other hand, when we talk about Parkinson's, we have limited options, okay? So we do have anti-Parkinson, we have reversible, we have irreversible. Of course, the preferred one are the reversible. So then with the anti-Parkinson, you would use reversible inhibitor for this, and you would treat Parkinson, you know, as one of the drugs available, but you would have to advise the patient to avoid anything that has cheese, okay? Because you don't have many options. Or you could try something else other than the MOA inhibitors. We have studied the anti-Parkinson medications, so it does not have to be the MOA inhibitor, okay? We could use, remember we talked about the levodopa and the carbidopa, right? So that's one option. We also talked about, what else? Yeah, so it was the dopamine agonists, right? The dopamine agonists, I can't remember the examples, the like ergotamine and the apomorphine, the natural products, right? What else? So we talked about, oh, the COMT inhibitors too, right? Oh, that's a good question. Is it just the cheese or the dairy product? All dairy? I think it's just the cheese. Otherwise, it would be, because dairy product is more serious. Yeah, I think it's just the cheese. But that's a good one. I mean, that's your homework, okay? Okay, so I think these are the major ones that we had issues with. But it's an open discussion. Let me know if you have anything that was not clear in today's, either the rat or the, you know, exercises, I mean, the application exercises. Yes, sure. Okay, so if I remember correctly, orthostatic hypotension is when you suddenly stand up. So you're lying or sleeping, and then you suddenly stand up, then you feel the hypotension, okay? So that's the definition of orthostatic hypotension. In fact, we will learn about cardiovascular drugs next week, and we will talk about the side effect of some of these drugs, which is orthostatic hypotension. Because in theory, when you stand up, your heart should work faster, and then you should avoid that. But if you block the heart, then when you stand up, you're gonna feel the hypotension, you're gonna feel dizzy, okay? You might fall. So you should advise people to watch for that. We will talk about this when we talk about cardiovascular next week. Yes, ma'am. Say it again. Oh, Friday? Yes, of course. Well, I mean, you know, the deal, if there is no, unless you promise you'll study for the material, you're lying. Liar, 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 liar. Why would you study if you don't have an exam? I wouldn't. Say it again. I did not specify. Say it again.
Which material?
My material.
Which material?
She's asking why. Yeah.
But you understood that we were saying we study the material.
Oh, the material, right? See?
We study the material.
Yeah. Which material? See? Exactly. See, that's why you have reading objectives that covers the important points. And unless there's a rat, you're going to be having fun Thursday night.
Okay. This class is
Nobody's having fun this week? You're not? Darn. Well, me neither. I'll be spending weekends preparing for your cat questions. This session is crazy for me. It's like Monday, Wednesday, Friday. I never done this ever, you know. So it's like 3 hours and just covering everything, mid-chem within just 8 weeks. That's why some of these topics, like, you know, I ran out of time and I just have to post the material, no videos, no exercise, nothing. But some of the other topics I taught already, I have, things more prepared for it. Good thing is, I think this lecture is the only one, the last one that I've never taught before, and the material is not finished. Starting next week and Friday, you will see more, applications and nice handouts and, videos. Not on all of them, but you will see more of that. So it'll be much easier. But we need to, yeah. Say it again. Yes, you do. I'm sorry? No. This is not a democratic. This is not democratic class, whatever. So, I'm being dictatorship here. Yes.
I don't have to solve that problem. Why don't we move your Friday materials Monday and do a review on Friday in class? For people who have to leave Friday after class.
Say it again.
Could we not move the Friday material to Monday and use Friday's class to review for the cat since it's going to be harder?
No, because I will lose one day. Yeah, and I need that actually. So, but we will, guys, we will have a review for the cat. Okay, we will. Okay, but we will also have a rat on Friday, and we'll have a review for the Friday lecture, just like that. If we finish early, if we don't, we'll spend an hour reviewing the material on Friday. It's very interesting. It talks about diabetes and all these insulin, and it's really exciting. So, but then I'm still trying to find out the time for the review. Would you be willing to come on like Sunday? Okay. I'll keep that in mind. I don't want to promise yet. I have to check with my wife. First. I was thinking, well, Monday is the exam, so I was thinking if we can come on Sunday sometime, I'll let you know at the time. This way, we'll give you time to study. This way, we'll give you the time to study Friday night, Saturday, and then sometime on Sunday, maybe like in the afternoon. Then, no? Some people cannot come here. Well, I will record the review. I will record it, okay? This way, if you cannot make it, this way you have more time to study, and then you come up with questions, okay? So, but it's not, confirmed yet, okay? I wanna, make sure I have nothing on Sunday. I wanna check with my, my boss. Anyway, so we do not want to waste the time. So any questions about the cat or today's lecture? Was everything clear in today's lecture? Okay. So any questions about the cat or anything of the previous lectures? Yes, ma'am. Yes, exactly. So the cat material will be starting on the 7th, the 7th, which I think was on a Friday, and we had the analgesics, CNS analgesics, covering everything until today's lecture, including today's lecture, which basically all the CNS, right? All the CNS drugs, all the difficult stuff. Well, I'll make sure that on Sunday to clear anything that's not clear, okay? And I know, guys, some of the, okay, when you study for the cat, focus on the points we covered on the class only, okay? If you see something in the note that is not being mentioned or covered, you can skip that. So you have RAT questions, you have application exercise, you have video recorded, like now we're recording today's lecture. So you can go back and visit that, make sure all the concepts we covered are clear, and these are the questions that will be involved, on the cat, okay? We will have 50 questions, 25 on my part, 25 on Dr. Pearson's part, okay? Because we have equal number of lectures. I taught five classes, and he taught 5 classes. So we have 25 questions on, from each instructor. And so roughly will be like 5 questions on each class, on each topic, okay? What else? And again, we'll have an ICAT followed by a TCAT,
hopefully we'll not have any issues with the exam soft. Yeah. Yes, Melody. Thank you. Yes. So just yes. So normally in class I cover the reading objectives and I cover them through RAT, questions and application exercises. So the best way to study is to look at all the concepts we covered in a class, whether RAT or application exercises. So you could watch the video that we post. Everything is posted online for the CAT. You could watch these, make sure you understand everything. And I guess the main issue is if you go through the material and you find something that irrelevant, we did not discuss it in class, or we did not have question on it, and the RAT or applications, then you could just ignore it if you want to, okay? I know you want because you like to learn, but
Even if it's only objectives.
well, I covered all the objectives in the class, so I can't think of an objective that I did not cover unless it was like a simple one. But if it's in the reading objectives, then you really should know it. Okay. What else? So as far as the SAR, you will see, just like we had in the CAT 1, you don't have to memorize it. Just make sure you are familiar with it so you can use it. But do not wait until the day of the exam to read it, right? So you should be familiar with it. So when you see it in the exam, you can actually use it instead of, having to study it during the exam. Okay. Okay. Any questions? Yes, sir. How long? So about the same time, an hour and 50 minutes for the ICAT, 10 minutes break, and then TCAT for 1 hour. Okay, so I think that was a good break for the time. What else? So normally we would review after 12 today's lecture. So I'll be in my office since we covered everything. I'll be in my office because I have students who want to review their ICAT, and I also have other students from other classes. They also wanted to review. So, but if you want to like have another like 30 minutes for today's lecture, I'll be glad to do that. This is the plan. So, we can break and come back at 12, and then if you have questions about today's class, well, if you do, you can come to my office, okay? Okay? Any issues? Any questions? No? Okay. Well, good luck. And please don't forget to turn the sign-in sheet